Today, we're here at a panel to talk about how we might reimagine equitable health systems for thriving people and places. If that's the session you think you've come to, you're in the right place. And I'm delighted to welcome all of you here today for this important conversation. You know, our work requires us to have transformative conversations. And that's what I hope our panelists will help us to frame today, and what I hope all of you will have with us, but also with one another as you leave this session today. Today, I'm delighted to welcome my panelists, but I've been told I also have to introduce myself. I'm Shoma Saha. I'm President and CEO of Wellbeing and Equity in the World, We in the World, and the Wellbeing in the Nation Network. And both of those work together to advance intergenerational well-being and equity on a foundation of racial and economic justice. I've been told that's a really long thing to say. So more recently, we've come to say that what we're really about is powering a movement of better ancestors, people who can know and understand how we got here in ourselves, in our communities, and our nation, and have the courage to be the leaders that can create what's needed in legacies for the next generation, the next 7 generations. So that's the kind of transformative conversation I'd like to invite all of us into today. What does it look like for health systems to act as better ancestors? So I could not have a better set of people to help think about that with us, each bringing a very different and unique piece of the puzzle. To my left here, we're delighted to welcome Jaime Wesolowski, President and CEO of Methodist Healthcare Ministries, and we're going to start with Jaime at the beginning of this session with a couple of questions. But Methodist Healthcare Ministries has been a real supporter of this kind of thinking and work and bringing that into the Aspen Ideas Health Festival, and I just wanted to thank you for that leadership here in this space. Next to Jaime, we have Katie Bollbach, Executive Director of Partners in Health in the U.S. How many of you have heard of Partners in Health and know its work globally? How many of you know its work in the U.S. and what Partners in Health has done, not only Indigenous communities in the Southwest, but in the context of the pandemic across the nation? If you haven't, I encourage you to read their website and Katie's bio as she talks about how PIH and US has worked to build stronger community-led public health infrastructure, more robust community health workforce, and a more just US health system. Dave Chokshi, next to him, is the chair of the Common Health Coalition, and many of you know him from many, many roles in the past, working, for example, as the inaugural Chief Population Health Officer in New York City Health and Hospital Systems, and of course, as the Health Commissioner of New York City, as he led New York City's response to the COVID-19 pandemic in partnership with the communities that were experiencing injustice. Dave has started a new initiative co-led with Derek Hamilton on health and political economy, and I hope we get to some really juicy conversation about that. But I'm going to start with you, Jaime. So Jaime, when I first met you as the president and CEO of Methodist Healthcare Ministries, I remember you asked our team to help you think about what Methodist Healthcare Ministries could do to really achieve your mission of improving the health and well-being of communities in the south of Texas. You looked at your history and realized that there had been amazing things that you had done, but you cared about doing something even more. Tell us a little bit about that story. Tell us about how you got there and how you got to the topic of this session and why it matters so much to you.
Absolutely. First of all, thank you all for being here. So I'm a frustrated hospital CEO, believe it or not, for multi-decades. I ran hospitals, I ran large hospital systems, and I focused on that 20%, if you will, right, of what really affects health. And I had the opportunity to come over to Methodist Healthcare Ministries, and one of the first things we looked at with the board is the great work that we're doing, which was mostly downstream at that time for 24 years or so. We had the privilege of taking care of the medical, dental, and behavioral health care of the uninsured. When I say uninsured, I mean people that weren't eligible for Medicaid, Medicare, insurance, nothing. As you know, Texas is unfortunately one of those states that has not had Medicaid expansion, so we have far too many people in that list. And so these are people that are working hard, doing the best they can, and their employer doesn't give them health insurance, and so they don't get health care. So we did that for 24 years, did a great job. It was very much needed. But when I joined Methodist Healthcare Ministries, one of the things that we looked at was the health outcomes. And the health outcomes were not only not getting better, they were getting worse, and they were getting worse for the population we served at a faster pace. And so we said, even though the work we're doing is so important, we have to do something else. And I was, again, coming out as a hospital CEO. I didn't know what I didn't know in this space. But I think it was divine intervention, quite honestly, that brought Dr. Saha to me. And she taught me and my executive team and our board eventually a lot about social determinants of health, about the moving upstream, and what to focus on. And so we really developed a strategic plan that started with transforming our internal culture and our processes, because to move into health equity, we had an entire organization of providers, healthcare providers. So I think at first, when we start talking about this, they thought we were bringing them witchcraft or something. Quite honestly, it's like we had to convince them that this is the right thing to do and get the culture right and get the processes right and getting them pulling in the same direction. And then it was strengthening communities, and that's where I learned the most from Dr. Saha, really shifting the power, working with communities, making sure that they are coming up with what they need and telling us, and empowering them to actually work on it, where we can walk with them. And that was all foreign to me until this lady here taught me about that. And then finally, it was really impacting systemic change. And I think that's where a lot of our innovation comes from. And I'll talk a little bit about that a little bit later. But that's really why it's so important to us, and how we made that shift from being mostly downstream to where we're getting to be a pretty balanced organization, where almost a third of our dollars are spent on upstream efforts.
Jaime, can I ask you a follow-up question about
Sure.
that? One of the things that was remarkable in what you were able to lead to as a CEO and get your board behind was that you were doing a 25-year look back to look at the fact that despite all that effort, things hadn't actually changed. But then the thing that you did that was so powerful is to imagine where you'd be in 25 years, what we would describe as a generational strategy, not just a 1 year, 3 year, driven largely by what would be the bottom line impact on the healthcare system. What helped you to do that, and why did that matter to you, and what helped you to frame that kind of generational strategy?
Well, I think I learned at the time, as a hospital CEO, you have the ability to make changes and see pretty quickly whether those changes have impact or not. And in this space, when we're dealing with public health and working in communities, I had to learn that it's a long-term effect. So we had to really make sure we spent a lot of time on what exactly we're going to do with our strategic plan. In the hospital space, we didn't make 10-year strategic plans. Basically it was a couple years at a time. And so we developed this 10-year strategic plan and knew that we were going to need to monitor it along, but we had to spend more time up front, making sure we prioritized correctly. The other thing I learned when I came over, I was so excited about all these possibilities, all these different social determinants of health, that I, of course, wanted to do everything. And my team, fortunately, said, Jaime, we got to prioritize. Let's do a few at a time. Let's do them right and focus. So that was very important, too. But as we did them, we spent a lot of time up front. And then once we pulled the lever, if you will, we made sure that we gave ourselves plenty of time to evaluate it, to to judge its effectiveness.
Thank you. So let's go down the line. What would you say as you think about your work, Katie, in the U.S. or globally, because you truly bring a lens to both in, as you think about these same factors, what have you learned and what do you think is needed to shift our thinking from health equity to just healthcare access, even knowing that in places like sub-Saharan Africa or indigenous communities in parts of the US, even that healthcare access is, of course, also an important part of equity?
Well, I was so glad to see a lot of folks here are familiar with some of PIH's work globally. We were founded in Haiti and work in low and middle income countries around the world with governments and communities on strengthening health systems. And so often that work first involves helping to ensure there are drugs on shelves, staff in facilities, safe and dignified spaces for care to be delivered. And there are certainly some of those challenges here in the US as well, as you mentioned. But I think coming, into this very different operating environment in the US, where we spend more than $4 trillion a year on healthcare, it's more than, it's almost 20% of our economy. It's just a different set of questions here around not total, abundance of resources available in a system, but about how those are allocated and who gets to decide where those resources are going. And so I think that's been some of our work over the last few years, is trying to figure out in this context how we can be supportive in community, in public health, in really helping to generate a different kind of conversation about where we're directing resources very hyper-locally as well as from a federal state policy level. And so I think that's, excited to get into some more specifics with this great group today about different very pragmatic and tactical ways we can do that in the short term, but also how we continue to build the movement for the right to health in this country, which is still far too nascent for such an abundant environment.
That's such an interesting shift from the right to health care to the right to health. That's interesting. Dave, you've been really going deep recently into what it looks like to do this work. What's, from both what you learned in New York and what you're doing now, in terms of political economy, what have you learned about what it takes to shift thinking?
Thank you so much, Shoma, and I really appreciated my colleagues' comments as well. And I'll just build on one aspect of them, which is what it will take for us to shift from healthcare to health. And there is no health without health equity. So for me, that is, part of the shift that we have to accomplish. And look, anytime we talk about the dysfunctions of the American health system, it usually starts with a couple of points that you all will have heard before. For example, we have a stagnating life expectancy in the United States for the first time in generations. And this is happening on our watch, so that should make us all feel a certain way about what's happening with respect to this very fundamental measure of health in the United States. And then in the next breath, we talk about the $4 trillion healthcare system and the fact that we do have one of the most, if not the most expensive, systems in the entire world. But what I think we elide over when we just talk about those two things, by themselves is all of the things that actually produce health, which goes beyond healthcare, as Jaime has already articulated. When I think about this from the perspective of the patients that I take care of, they don't necessarily care about living to 100. They don't necessarily think about their mortality or life expectancy in the same way that an epidemiologist might. What they care about is aging with independence and dignity, and having the strength to play with their grandchildren. And these are the things that I care about for my own parents and for myself as well. And so I think we have to come up with fresh approaches of talking about health in order to make that shift. And one of the modest proposals that I've tried to put forward is is the notion that each of us cares about healthy birthdays, and we should talk about it in that way, because there are millions of birthdays lost each year in the United States when we compare our outcomes, to those of peer nations. But we don't necessarily talk about this as birthdays lost or healthy birthdays. We, obscure it in the jargon of years of life lost, or mortality, or even life expectancy. And so I think part of the shift that we have to make is to say, this is what we actually care about, and therefore it should be a common goal, for anyone who is working across the health system. I think it also helps us get to a national goal. For example, in the United States, most people celebrate only a single healthy birthday after retirement age, which again is a fact that should just stun us. People work their entire lives and then fall into ill health, as soon as they retire. So what if instead we said, it is our expectation in this richest nation in the history of nations that everyone should have at least a decade of healthy birthdays, after they retire. A health span of 75 years. And the last thing that I'll just say on this is that by doing that, by setting a goal in that way that feels like it is common across all of the different parts of our health system and the health sector, there is a built-in equity imperative because, of course, Indigenous Americans, Black Americans, low-income Americans, their healthy life expectancy is further below that 75-year mark than everyone else. So we can both unite around this common goal for health and build in that equity imperative at the same time.
Dave, I've learned so much about you, about communicating about these things. And since we last spoke, I've shifted my language to, hey, we've lost 16 million birthdays on our watch. What are we going to do to get those back? That's 100 million bedtime stories at least, right? Because I think until we make this connect with everybody's experience, and at the same time, just as Rachel did from the main stage yesterday, think about what that means for what she wants to leave for Layla. I think we don't connect, we stay politicized on these issues versus connected on what it looks like. So we're not going to do this panel without getting down to what does it look like and how have you challenged the assumptions that are needed to be able to talk and work directly on things that affect things like racial justice. What are other, in places like Texas? And Jaime, this has been a journey. I remember how that conversation went the first time in your suites, and you're at a different place in how you're thinking about leading that kind of work and what it looks like to shift the balance of power. Tell us more about, for each of you, what are some of the assumptions you've needed to challenge to do this work in a way that has integrity? And how do you, give us an example about what that looks like.
Yeah, for us, like I said, it wasn't readily accepted from our workforce. So there were some challenges. I wish you could have read all the comments from our very first team member engagement survey right after we had started this initiative several months. And it made me just want to go back to the house and get in the fetal position. And it was a little rough, but we really worked on, once we set up our strategic plan, we worked on developing a department, if you will, of organizational excellence, and to make sure that we could educate our people, make them part of the change. And so I took our vice president that was over all of our clinical services and had been with Methodist Healthcare Ministries for quite a long time and tried to convince her to come and lead this department that didn't exist at the time. And so eventually, after about 3 or 4 conversations, she said, I will do it. And so we started with processes and culture. We started the Baldridge journey, where we really were not a process-oriented organization at all. And we needed to be if we were going to transform and get to the place we wanted to be. And we really included as many people as we possibly could on teams that would work through processes. And that was very important to go through processes. There are 4 parts of this department. The second part that was very, very important was our diversity, equity, inclusion, and belonging segment, department. And that was important because we went through a lot of learning, and I really thought I was in a pretty good place when it came to DEI until we went through some very extensive learning. And I learned so much through that point that, quite honestly, it made it sort of embarrassing to be a white guy. I mean, it was just tough when you go through the history. Through our DEI journey, we had to make sure that every one of our team members really understood some of the root causes of some of the health inequities that are out there that we're trying to work on. The third part was organizational learning, and we had a good learning program. However, we needed to realign it and move it from human resources into organizational excellence to make that part of our journey of transformation, so they could work closely with organizational excellence and with our strategic planning department. And then the fourth part was really going through evaluation, impact, and learning. Because we were an organization, as we were making changes along the way, we didn't really measure very well. We didn't really evaluate how we were doing. Is it having the right impact? And then regardless of where it is on that spectrum, what are we learning about it? If it's really good, are we learning to keep it going? If it's not so good, are we learning to make some changes? And so every one of those areas, I think, was imperative for us to kind of start that journey, make that journey, and get it to the point where it is now. And I think all my colleagues that are here from MHM would tell you that we're all pulling in the same direction now. It doesn't matter if you're a nurse working clinically, if you're a doctor, everybody gets what we're doing, and they understand why, and they're convinced it's absolutely the right thing to do. So we've come a long way. Really, and this department just started in January of 2021. So just in a few years, we've come a long way. So that's what was important for us.
Katie? Thank you, Jamie.
Yeah, I mean, I think, as I said at the top, I think, PIH believes so strongly that health is a human right, not just access to health care. I think we've made some progress in this country on talking about access to health care as a right, but in terms of access to health, I think there is a still very insidious underlying assumption in the way a lot of our systems work that health is a privilege or a commodity for sale or a courtesy or an act of charity to ensure someone is achieving their right to health and well-being. And so at PIHUS, we've been trying to work in community with community leaders, community-based organizations to support and accompany them in demanding their right to health. And then working on the other side of the table with government partners to support and accompany state and local health departments, federal policymakers to achieve, to advance systemically their ability to deliver the right to health to their communities. So knowing that there's work needed on both sides of that table. Our founder, Paul Farmer, who passed away a couple years ago, said at some point that, if we believe health is a human right, then the next question we have to ask is, who is human enough to deserve that right? And I think that's still a question we're really struggling with in this country. We work in Newark, New Jersey, an amazing city, predominantly black and brown, large immigrant population, large population living below the poverty line. You drive 13 miles down the road to North Bergen and you lose 20 years, or you gain 20 years in life expectancy. So what's going on there that, I think that is a systemic failure and something that we can't just look at. There's extraordinary healthcare facilities and innovation going on in New Jersey, in the city of Newark, and yet that disparity has persisted for so long between predominantly black and brown cities and wealthier white counterparts that are just a couple miles up the road. And so I think that's the work of really, again, working deeply in community to be driving the agenda, demanding access to the services they most need and want, paired with the work, federally and at a state level to do the systems reform that will create a better enabling environment for everyone to thrive.
I see Micheline Davis in this room who has been thinking about that, so you two will have something to talk about. But Katie, I remember so many 4 a.m. conversations with Paul, who really so many years before said that if the issue is structural, we need to think about it in a structural way. The solutions have to be structural. Dave, tell us about how you've been thinking about that and what assumptions have you been challenging and what does that look like?
Yeah, thank you. In terms of the assumptions that I think need to be challenged, one that I've been thinking a lot about is the economic orthodoxy that prevails in the United States. The primacy of free market thinking that is underpinned by cultural narratives of individualism and deservingness, as Katie just articulated. Who is deserving of certain rights, certain privileges, and this set of economic orthodoxies is sometimes labeled neoliberalism. But I would say the label is less important than what it represents, which is essentially total faith in markets and zero faith in government in many cases. This set of economic orthodoxies has shaped our society in so many ways that are invisible. I've struggled to come up with the right metaphor to describe it, but the one that comes to mind is the way that gravity shapes the curvature of space-time. It's something that exists, it's invisible, it's all around us, but we don't necessarily even unearth it, for what it is. The economy, of course, is far from natural. It is created by us. It is created by human beings, and therefore it is modifiable. It is able to be shaped by our decisions and choices as well. And that is fundamentally what, as Shoma articulated, what the Health and Political Economy Project is trying to do. By finding common cause with movements, for example, in the climate sector or in law, where there is a lot of intellectual ferment about what comes next. If we agree that this economic orthodoxy is not working because of everything that we have laid bare with respect to inferior health outcomes in the United States, then how do we actually paint the beautiful tomorrow of what a better world, can look like, and ensure that that new economy is one where from the get-go we are thinking about thriving people and places, as the title of this panel suggests. We are thinking about health as something that we should produce as an outcome from the economy that we have right now. And look, I know all of this can sound a little bit abstract, so let me give maybe a more concrete example. And I hear people talk about investments and costs, and I think we should all pay a little bit more attention to what is deemed an investment and what is deemed a cost. Too often, when we are talking about healthcare for people who are low income, for communities that are marginalized, when we're talking about a public option or a right to health, that immediately gets labeled as a cost. And the next sentence is, well, it's too expensive, for X and Y reason. But if you pay attention, the private sector and people who are very savvy about using the language of investment will say, for whatever it is that they're trying to do in a world that is dominated by business or the markets, things get labeled investments. And often those investments are outlays, of resources that benefit people who are already in the upper rungs of the socioeconomic hierarchy that we have. So I think one of the ways that we can start to change this is for those of us who do care about the issues that we've started to talk about on this panel, to be more savvy about using the language of investment and challenging the label of costs.
And that's not just a language issue, it's actually how OMB, for example, decides to categorize a policy investment. So really thinking about the roots of what it would take to change it. Thank you for that concrete example. So this is lightning rounds, 1 minute each, I think is what y'all get. So if these are the mindset shifts that are needed, what would it take for organizations to reimagine how they can deepen their impact? And what innovative risks are required to reimagine equitable systems for people and places? What's your best idea?
I would say it's really releasing the power to the communities for us. It really is shifting that power. I mentioned this earlier. Really working with our communities of solutions, which we call Prosperamos Juntos, thriving together. And if you want to know anything about our program, Jennifer Knowlton right here is the person to talk to. I can take you to 30,000. She can take you to what's actually happening, boots on the ground. But it's a powerful program. We have 20 different coalitions across our service area that have told us what their biggest gap is. They have developed a business plan with our assistance. We are funding it, but they came up with what they need to do. They are doing the work themselves. We are just simply there to walk with them. And it's a powerful thing. And even after I started understanding that it made some sense to do that, it's hard for somebody that is a control freak and as a hospital CEO to say, just let go and let them do their thing. And we have learned that is the right thing to do, is to let them work on it. We'll be there with them. We're going to help in every way we can. But I think that's the one thing I think I would put out there for us.
Thank you.
Maybe to draw on your reflection a little, I think one, it's just so important we're able to call out and name the structural drivers of what got us into this deeply inequitable place, and to be able to continue to call out and critique the upstream economic systems and politics that are allowing us to sustain such a deeply inequitable system, while also putting one foot in front of the other and continuing to improve well-being and alleviate suffering today. And so we at PH call that pragmatic solidarity. You've got to show up and help move resources and get things done today, while also being able to offer that structural and political critique of where we are. So I think for us at PHUS, that has really meant, I think in a similar spirit, a focus on supporting things like health equity communities of practice that try to create more sustainable platforms in communities where public health, local health systems, community leaders, and activists and organizers can get together and have a platform to align on some shared health equity priorities, and then have the commitment of some of the actors with more resources at the table to move real meaningful policy or program work forward. So we're doing some of that work now in New Bedford, Massachusetts, and have a few of our partners in that work here, but that's got to be not 1 year grant-based, time-bound work. That's got to be building collaborative infrastructure that can really be sustained and endure, not just in moments of crisis like COVID, but that can really be a place where relationship is built and power is shifted and ceded and taken in different ways to really, again, shift who's sort of driving the policy decision-making and resource allocation. And secondly, I'd just say, around the world, community health workers are the heart and soul of community-based equity-centered health systems where PIH works. And we have, some amazing history of community health worker organizing and programming in the United States over the last 60 plus years. But we have so much more work to do to really elevate and invest in that workforce as so essential to navigating our deeply fragmented, inequitable present state, as well as to be advocates and organizers to really help do some of that systems change work. So I have a colleague from the National Association of Community Health Workers who was supposed to be here with us today but got stuck in Denver, but we're doing a lot of work with the National Association on place-based work, but also national organizing work among community health workers to really elevate and advance that workforce as essential, both to meeting immediate needs today, but making some of those structural shifts in our system as well.
The innovative risk that I would add is simply believing that the public sector can do big things. And I have to invoke my experience during the pandemic when I had the privilege of serving as New York City's health commissioner, where we vaccinated 6 million New Yorkers against COVID-19 in a little bit over a year. And we did so much else. We built a field hospital in a tennis stadium, during that devastating first wave. We shifted the entire apparatus of our health systems to telehealth almost overnight. And I worry that in this, pandemic amnesia or fatigue that we're suffering from, which I get it, I sometimes I'm tired of talking about COVID-19 as well. But I worry that we're throwing the baby out with the bathwater when it comes to those Herculean tasks that we were able to accomplish, and that government, that public sector, played a leading role in organizing. It's not only the public sector, of course. We would not have been able to vaccinate 6 million New Yorkers were it not for a cadre of over 500 community health workers called the Public Health Corps, whom we activated and funded during the pandemic because we had a belief that this was fundamentally the workforce that we should have had, before COVID-19 hit in the first place. So those are, sort of the examples that really leap to mind for me. For us to, again, challenge this orthodoxy that is particularly American with its vehemence, that puts, total faith in the markets and zero faith in government.
Whew, small ideas that they have over there. I'll add to that the ability to conceive in long-term generational change and to invest in that. What if we could believe ourselves capable of interrupting the transmission of racism? What if we could conceive of interrupting the cycle of generational poverty in a way that creates shared abundance? And how might we lift up the stories of what we already showed we could accomplish, just as you were talking about, Dave? So, last question for all of you. When you imagine the health of future generations, what's a legacy you dream of leaving behind as a leader?
Before I answer that question, I just want to say I'm learning so much. I hope you guys are learning too. I'm learning so much, and I learned from Dave that I'm never going to retire now.
That's right.
Right? That's one way to fix that. I know that's not what he meant, but anyway. So for me, my sincere wish would be that I'm known, my legacy is that I challenged my biases, I challenged my past experiences, I challenged my past expertise, because I feel like I do have expertise in running hospitals. I'm not certain I have expertise in this space yet. I'm learning as fast as I can, but that I challenged all that, and I moved myself from only focusing on that 20% from Robert Wood Johnson to being able to focus on everything. We are broadening the definition of healthcare at Methodist Healthcare Ministries. We will continue to do direct care, and we'll do it very, very well, which we do. And at the same time, we will prioritize community by community what biggest gaps they have in social determinants of health and address them with the same effectiveness. So instead of focusing on 20% of the pie, I've been able to expand my horizons, thanks to some people here, to be able to focus on 100%. And I hope that's what my legacy is at the end of the day.
I'm going to offer two. And one, building on Dave's reflection, I'm a born and raised New Yorker. I went to get my, vaccine at a New York Health Department site and, went up to get the shot, and I burst into tears, and the nurse, I said something like, "Oh God, you must get this all the time," and she said, "Not really." I was like, and one, loved that salty New York, just rounded out the New Yorker experience of it. But the reason, I think there was, of course, relief and gratitude for this miracle of science in this moment, but it was more sitting in the waiting room after, kind of watching government do this big thing and kind of watching us mobilize as a city and a country in this extraordinary way, and being reminded that that was possible in moments when we get so cynical about what government can do and the ability to do big, ambitious things. And so I think holding on to that, I think in our work with PIHUS, really want to continue to push for an advanced continued investment in public health infrastructure in state and local and federal public health as essential services, not folks you call when the next pandemic hits in a moment of crisis, but as sort of essential bread and butter services we have to invest in better. So anything that we can do to support the movement to continue to better fund and elevate the role of public health in our life feels critical, and it would be something we'd love to contribute to. And then second, as I said, community health workers are doing such extraordinary work around the country today, but so often underpaid, underappreciated on time-bound boom-bust grants where job security is a huge challenge, and that workforce is predominantly women of color, often living under the poverty line even when full-time employed in these roles. And so we really want to support the community health worker-led movement to advance and elevate that workforce in our country, and to invest in and sustain it as a foundational component of a more equitable future.
When I imagine the future that I hope for, I can't help but thinking of my daughters. I have two young daughters, one who just turned 5, and the other one will celebrate her first birthday in just a few days. And what's coming to mind is when my wife and I drop off our elder daughter to preschool, we've taken to repeating what has become like kind of a mantra, which is be gentle and kind, ask good questions, and have fun. And I'll say my daughter is really good at the asking questions part. She asks why, and then she asks why some more, and then she asks a third or fourth why. And I've really tried to derive inspiration from that, and what I hope part of my legacy, our legacy will be, is that we were seen as a generation that asked why, that asked the most important whys. Why are these widespread inequities allowed to persist? Why didn't you do more if you said this was happening on your watch? And not being satisfied with the superficial answers, and instead, just like my daughter, continuing to ask why upon why, so we can get to the deep structures of what needs to be changed in our world.
Every morning these days begins with a conversation with Black farmers. Something you should try. Reverend Joyner, who some of you might know, is someone who, when he describes what it's meant for him at the age of 70 to do this work in rural eastern North Carolina, a community that began 100 out of 100 in health rankings a few years ago, was one of the worst food deserts in the country, and is now a food oasis, climbing up those health rankings. He talks about being one of 17 children in his family, many of whom are gone, where he's one of the only ones in his community that people can see are living to the age of 70. People have come to normalize dying in their 30s, 40s, 50s. And so I asked him this morning, what does it mean to you? He said, what it means to me to live that better world is that kids are growing up expecting that their parents will be there to watch them graduate from high school. That people will expect to be there for their grandkids in their 70s and their 80s. And for me, it means that none of us have to work quite so hard around a system that doesn't work to produce a fair chance for everyone to have the right to a good life. I'd love to invite all of you to think, what does it mean to you to be ancestors creating that legacy? And if anybody would like to share, we have about 5 minutes, or to ask our panelists some questions. We have some mics in the back of the room.
Thank you all very much. My question is actually for Katie. In the context of what Dave was talking about with capitalism, and I could argue that health and what we would say are cultural determinants of health is inextricably, intractably linked. I'm curious to know, in your work around the world and in the United States, how do you entertain indigeneity? How do you look at indigenous determinants of health, which can often be in conflict with cultural determinants of health, and resolve that for successful outcomes in Indian country?
So we have a sister organization, COPE, that works in Navajo Nation, who are just doing exceptional work there and thinking about really leading with indigenous wisdom, knowledge systems, ways of thinking and caring, and building, different types of programming and services and community around their work, who I think are doing exemplar work, who I would point to as sort of great examples. Here, I think there is a kind of essential component of relationship building and engaging in that open-ended long-term way, and thinking about that seventh generation lens of so often, we get stuck in these transactional, time-bound, we need to see the results 6 months from now, or, game over. And so I think we have so much to learn from indigenous knowledge systems and ways of building services that center community, that think about the past and the future in such a different, better, and sort of more inspiring way than the sort of capitalist-infused way we approach health and relationship these days. So thanks for the question.
Yeah, indigenous perspectives have often been missing in this conversation. And I just want to thank you for calling that in, as well as noting how differently, how much richer this whole conversation becomes when we think about those connections to land and culture. Yes, please.
Stephanie Diaz. I'm with Catalyze by Wellstar, which is the innovation company and venture fund attached to one of Georgia's largest health systems. And health equity is one of our focus areas. I would love to know how you've seen technology support your initiatives, or how you would love to see technology come alongside and support these initiatives.
Any of you?
Happy to start briefly. My take is that there's a huge role for technology to play, but in my experience working in a health system, and working in public health, the mistake that we too often make is not recognizing that technology has to be subservient to relationships. What is missing in sounds like some other people have their own experience with this. I'll just leave it at saying that technology is almost never a panacea, and what we are missing in so much of, the ebbing humanity in our health system is more of a focus on relationships. Technology can help to lift that up, but only if one is very deliberate about the fact that technology has to be subservient to relationships.
This is sort of a question, but also a thought piece. So it's inspired by you, Jaime, when you were talking about power sharing. And what I understand implied in that is really having more community-based solutions. And I have seen that implemented in health systems and even other systems across the board. But what I haven't seen is how the community-based solutions actually inform how we define and measure success. Because at the end of the day, when we talk about inequitable systems, we're talking about an imbalance in power. And so having those community voices actually determine and define how we're measuring success is what's really important. That's what true power sharing and true equity looks like. So it is, again, a thought that I want to plant, but if you have an example of how we have actually changed how we're defining and how we're measuring success based on that community input, I think that would be very helpful for those that are assembled here, but also for the field.
First of all, I think you're absolutely right. And we're so early into this, I think we're right at that point now where we're getting to that, learning, because we only have, our cohorts are only, we're in our 4th cohort now. So our oldest cohort has only been going, 3 years. So it's still fairly fresh. We're at that point now where we are really learning from them and learning how we can take the learnings from our communities to help other communities, basically to your comments. So we're kind of at that point now, I think. I don't know, Jennifer, I know you don't have a microphone, but you might want to add a little bit to that because this is her baby. And we're at that point where I think we're taking it from learning to expanding.
Yeah, absolutely. Thank you. Hi, Jennifer Knowlton. I'm with Methodist Healthcare Ministries. I oversee community health and wellness. And as we're thinking through our process and working with, our coalitions are made of cross-sector organizations and the people whose lives they're trying to impact. And we still grapple with what is the right term for that. Persons with lived experience, persons with living experience, community leaders, but who are you working with? And they have to be a part of that evaluation process. And we've started on that journey of looking at formal evaluation, and I will tell you that one of the big lessons learned so far is we're changing the language. Evaluation's not a term that's resonating. They want to call it continuous learning. And we started with an evaluation consultant, and actually, because of some interactions, that consultant, with the decision of the committee that involves the people, we terminated that contract, and we are looking at, we're re-looking at how we are thinking about continuous learning and what that means, and then not only including them in that decision making, but then where does that live? And the community owns that. And so how do we make sure that they're continuously a part of that process? Hope that helps.
So thank you so much to all of the panelists. Thank you to all of you for being here and for thinking about this together. It's been a privilege to be with you.